chương trình thầy nói có một bài nhưng mà thầy rất quên nói thêm bài nữa. Thầy sẽ nói một bài về khô mắt, dry eye, và cái bài thứ nhì là thầy sẽ nói về cái tế bào hormone môn. Còn giáo sư Tân thì cũng nói hai bài luôn, nói một bài về nhiễm trùng và một bài nữa là ghép giác mạc lớp.
Shall I go over there?
It's up to you.
Okay. So I
What do you feel from Shepos?
Well, thank you very much for coming. And now I'd like to talk about the dry and kind of meibomian gland diseases. So this is a kind of overview for 30 minutes or so. And then I will talk about corneal endothelios. Okay, so first of all, you have already know how to diagnose and the treatment of the dry eye and meibomian gland diseases. But I'd like to divide it into 4 or 5 subdivisions. And then I'd like to start from a diagnostic criteria for dry eye. Well, here. Thank you. So the tear fluid, as you may know, they have a lipid acus and a mucin layers, especially the mucin layer. The Japanese are very much interested in the mucin layer. There are 2 components of the mucin. One is a secretory mucin, the other is a membrane-bound mucin. Membrane-bound mucin among them, especially MAC16. MAC16 is a key, and all the cornea or conjunctival epithelial cells, surface of the epithelial cells, they're supposed to express MAC16. So because of that, tear film is very easy to spread out over the ocular surface epithelial cells. In addition to that, secretory mucin, these are coming from the goblet cells. Well, and then for the lipid layers, these lipids are coming from meibomian gland. Most of them are non-polar lipids, either the wax ester or the cholesterol ester. But not only for that, because the lipids and water, they have a fight together. So they need some of the lipids that make the good affinity to the water. So therefore, phospholipid, polar phospholipid is also in the surface of the tears as well. And also the movement of the eye. Usually the tears not coming from the upper portion, they are coming from the lower to go up with the blinking. Let's look at the central part of the cornea by interference thumb. So this is a high magnification of the tears. When I blink, the tears move upwards. So that even in a meibomian gland has a lipid layer. So these lipids go up from blinking. So the blinking is also the key for the maintenance of the ocular surface. Well, this is the major etiological cause of the dry eye, according to the Dew's report, 2007, I think. Steve Kuffel and myself, we are responsible for making this major etiological cause of the dry eye. At that time, we divided into 2, acus deficient and evaporative dry eye. And when we're thinking of the dry eye, about the 10% of the total dry eye belongs to the acus deficient. About 90% of the dry eye, they belong to the evaporative dry eye, at least in Japan or in Singapore or so. So most of them, either the meibomian gland, some of the program, or Greek program, or some of the environmental program or so. So that, as I said, 2 types of the dry eye existed. One is acus deficient dry eye. The typical one is a Shigeru syndrome, or so actually with rose-petal staining, you can see not only for the cornea, but also the conjunctival epithelial staining as well as also. evaporative dry eye, on the other hand, they had a kind of a short BUV, and you can see, even though there's a normal tear fluid, but still they have that so quick evaporation from the ocular surface. Therefore, that is also the dry eye. In addition to that, we are now proposing the short BUV type dry eye. There's no SPK, superficial punctate keratopathy, but after blinking, suddenly they already had a kind of spot breaking. So these patients have lots of complaints, but without any superficial punctate keratopathy. So we did not know how to treat them properly. But that is probably because of as I mentioned to you, some of the area of the ocular surface has a lack of the expression of MAC16, or some kind of membrane-bound mucin is not existed, or they are low expression of the MAC16 or so. So that's the reason. In addition to that, cause of evaporative dry eye, that is, first is informational technology. Use a lot of computer, the decrease of the blinking, the number of the blinking per minute or so. Usually we blink like 10 times per minute or so, but when you use a computer, sometimes just once or twice per minute. When we perform the like a cataract surgery or so, we didn't blink at all, so because of the concentration to see. So that makes the evaporative dry eye as well. And the air conditioner with the contact lens, and also the gender. The women is more susceptible than the men regarding the dry eye. It's because of the androgen is one of the key for the secretion of the oil. So therefore, as I said, women is more susceptible to the dry eye. And also the obstructive MGD are also some of the cause. Well, in addition to that, air pollution. Air pollution is one of the key, because air pollution makes the oxidative stress. That oxidative stress is quite bad for the tear film. Also smoking. Smoking is also quite bad for the dry eye as well. Well, number 2 is impaired visual function associated with dry eye. When you can easily understand a normal ocular surface, or cornea itself, especially the surface of the cornea, that is more like good optical quality. If you have a good optical quality, you can see, you can get a better vision. But when we have a dry eye, the surface is a kind of irregular, even though we couldn't detect like a corneal irregular astigmatism. But still, the higher order aberration occurs, that becomes higher and higher. So that means that when we think of the lens for the camera, if you use a good quality of the lens, you could get a better picture than the other one. The same is true for the humans. So therefore, when the dry eye patient, their ocular surface is not so good quality. So therefore, they try to see with the bad quality of the lens. So therefore, they had the fatigue, the eye strain or so. So it's because of the bad quality of the lens. How we treat them? Well, there are at least conceptually 3 ways to treat the dry eye patient. The pharmacological agent, so they're divided into 3 groups of that. One is an aqueous retention or the secretion. Probably you use either the artificial tear or hyaluronic acid or methylcellulose type eye drugs or so. These are for the aqueous retention and secretion. That is a promotion for that. And then anti-inflammatory. Although the dry eye itself is a bit related to the ocular surface inflammation, but that is sometimes it's not obvious. It's more like secondary to the mechanical friction, but in a biological point of view, they have some kind of increase of the cytokines or so. So therefore, try to decrease the inflammation that is effective. Sometimes cyclosporine eye drops or low-dose steroid eye drops, especially in the Sjögren syndrome or so. And number 3 is a mucus secretion. In Japan, we have 2 eye drops commercially available to increase the mucus secretion. One is the dicarboxyl sodium, the other is a revamidine. Dicarboxyl sodium not only increase the mucus secretion, but that is also increase the ACUS retention, but actually ACUS increase the volume of the ACUS. On the other hand, revamidine, that is increase the mucus secretion. Also, they have some kind of anti-inflammatory effect as well. Well, for instance, for the mild to moderate dry eye, we probably start using the artificial tear and hyaluronic acid eye drops. And then the dicarboxyl sodium. Dicarboxyl sodium is quite effective to, as I said, increase the mucus as well as ACUS. It's because of this is the P2Y2 agonist. So stimulate P2Y2 receptor that eventually increase the intracellular calcium concentration. And then that opens the chloride channel. So therefore, water is also coming from the cell itself. And also the goblet cell release the mucus in the Golgi. So therefore, both of them, I think mucus as well as ACUS is released. Let's look at, this is a rabbit. 1 drop of the dicarboxyl sodium and artificial tears. You can see the remarkable difference of the ACUS secretion. In rabbits, and they could easily, I think, make a stimulus from the dicarboxyl sodium. But you can see the big difference. This is quite a repeatable result. So same as true in humans. So therefore, we are now decreasing the use of the platinum product because of the dicarboxyl sodium. And patients love to use the dicarboxyl sodium rather than the platinum product. So that is one of the reasons. So we actually measure the ear fluid secretion after the use of the 3% dicarboxyl the solution in normal human eyes. We use 1 drop of the dicarboxyl sodium, the other is artificial tears, and you can easily see like 1 drop increase the amount of tears, 10 minutes, 20 minutes, this is 30 minutes or so. So I think at least for 30 minutes, just 1 drop increased amount of ACUS secretion. That is an enormous side effect. So for instance, this is just a pre-treatment and 4 months later, this is a non-Sjögren syndrome, but this is kind of ACUS deficient dry eye, and the mucus tract is tend to disappear because of the increased amount of the tears. Well, revamidine, this is released from the other Japanese company, the Mendoza. This is the kind of drug for the gastritis. So they like to make some of the eye drops. This is also beneficial, but this is more like have a beneficial effect to the ocular surface epithelial cells rather than the tear itself. So the corneal epithelial cells become more normalized. For instance, membrane mucin is increased, that junction become normal, and the epithelial cell itself become more normal. So this is the very mild case of the Stevens-Johnson syndrome, and you can see that these SDK is gradually goes away, and also the listening green really shows the staining of the conjunctiva. but it's also gradually decreased. Well, Pantan plug. So we are still using the Pantan plug or the surgical occlusion of the punctum in very severe cases or so. But generally speaking, we try not to use the Pantan plug because they make the biofilm that area, and they had some kind of infection sometimes occurs. So this is a pre and post use of the Pantan plug. When we are thinking of the treatment of the dry eye, always drug toxicity is a key, because the patient would like to use many eye drops. Some of the eye drops has preservatives or so that could make some kind of adverse effect to the results. So therefore, when we see the patient who come to me or so, initially we try to eliminate some of the eye drop toxicity or so. So try stop using the most of the eye drops, and then wait for 2 weeks or so. This is kind of washing period, and then we now know how much ocular surface damage is due to dry eye itself. Well, and also when we see the dry eye in an elderly patient sometimes see the conjunctival caries, and then they show the kind of SPK or the superficial epithelial damage to the bulbar conjunctiva. At that time, they made kind of ectopic tear meniscus as well. So therefore, some of the patients with the conjunctival caries also develop the dry eye. So in this case, he or she had kind of irritation, druglimation, and drug vision. How to treat the conjunctival caries? This is if you ask the patient to make a forced blinking, and then you can easily see these conjunctival caries. At that time, we try to remove some of the tissue from the lower portion of the bulbar conjunctiva, and then make some of the anesthesia, and then cut about 3 millimeter or 2 to 3 millimeter of the bulbar conjunctiva, and then try to make some of the shortening. Not only for the FDF, but also the subconjunctival tissue, we try to remove it. And then it's a bit tedious way to do that, but if you try to be accurate to dissect the 2 millimeter in length or so, we usually perform this kind of that surgery. And then divide it into 3 parts. But you don't have to do that. I think at least if you make a 2 to 3 millimeter strips, if you could remove and the suture, the patient will become quite happy. So this is actually after the surgery, the disappearance of the conjunctival caries, and patient become quite comfortable about breathing or so. And also eye itself become juvenile. Especially the women, they love to have this kind of surgery. So the what is the diagnostic criteria for meibomian gland dysfunction? Well, most of the time, at least in a Japanese patient, elderly patient, they develop obstructive MGD. So obstructive MGD makes the evaporative dry eye, and this is the typical feature of the SPK caused by the obstructive MGD. This is one of the causes of the evaporative dry eye, and so this is the kind of alteration of the meibomian gland. We call the meibomian. Meibomian, they have a unsaturated free fatty acid or so, that will go to the saturated fatty acid, and also they have a straight chain fatty acid or so. And then if so, their melting point comes from 14 degrees to like 70 degrees in centimeter or so. So therefore, they are very difficult to make a kind of oily solution. So that's one of the reasons for the meibomian gland obstruction, difference of the melting point because of the alteration of the meibomian. So there is some kind of diagnostic guideline for meibomian gland dysfunction. But at least this is a Japanese guideline, but there's no definitive clinical definition of the meibomian gland dysfunction. At least we Japanese, we use this. MGD is a multi-dysfunctional state of meibomian gland due to various causes accompanied by chronic eye discomfort. Doesn't mean anything, at least subjective symptom and abnormal duct orifice, like a vascular elongation, abnormal mucocutaneous junction, irregular lid margin, and obstruction of the duct orifice. Something like that. Well, number 5 is the critical association between meibomian gland and ocular surface. Not only for the evaporative dry eye, but also sometimes we see the inflamed MGD. Usually this is a non-inflamed MGD that could cause the evaporative dry eye, but sometimes inflamed MGD, especially this is a meibomitis, and there's some of the ocular surface inflammation. We wrote the review paper in ocular surface last year. Obstructed MGD is divided into two. That is a non-obvious, non-inflamed MGD. The other is an obvious inflammation curve. And then this situation is also divided into two. One is, as you may know, Charlechium. Charlechium is one of the inflamed MGD related. The other is a meibomitis. Meibomitis eventually makes the 4 different named ocular surface disorders. We call meibomian meibomitis related keratoconjunctivitis, or ocular rosacea, or pretenular keratitis, or childhood peripheral keratoconjunctivitis. I'd like to show you this. This is the meibomitis related keratoconjunctivitis. Usually we see the young children till the adolescent or at the age of 20 or up to 30 years of age. And predominantly I think seen in female, not male. Maybe 9 to 1, something like that. So you see this tiny meibomitis, related to this region. So that means that this is a pretenular keratitis. Used to be, if we have a tuberculosis, the tuberculosis might be the causative the factor, but this meibomitis closely linked here, and this is a moderate, and this is a severe form of the meibomitis as well. So we are thinking at that time the P. acne, Propinium bacterium acne. That is also a strong inducer for the Th1 response. It's more like tuberculosis. And sarcoidosis may be also related to the P. acne involvement in systemic. Anyway, as I said, this is the severest form of the MLKC, 28-year-old female. When we encounter, she is a bilateral. The visual acuity is almost non-motion. So that we are thinking that elimination of the bacteria such as P. acne in the meibomian gland will be essential for curing ocular surface inflammation. This is not the corneal infection, but it's a more like a bacteria-related or the induced the allergy type reaction. So that this concept is basically quite similar as for gastritis associated with Helicobacter pylori. So therefore, we intentionally use the systemic administration of at that time cephalosporin and erythromycin without any use of the steroid. And then you can see this is the same patient about 1 month and 3 months after the treatment. So elimination of some of the bacteria, we expect the happening, but that is worthwhile to try it. And now not only for the erythromycin, the other drug is effective as well, especially the macrolide or tetracycline pathways. So this is a picture I took from the literature. This is a pediatric ocular rosacea with linear keratitis in childhood, red keratitis. This is a meibomian related keratitis. Almost the same. So when you see that these kind of ocular surface manifestations, please look at the lid margin, especially the superior lid margin. And if you see some kind of meibomitis, please use the, I think, at least the antibiotics or antimicrobial agents systemically. Well, this is almost the last severe ocular surface. We've already seen the Stevens-Johnson syndrome. Stevens-Johnson syndrome, about, I would say, 60 to 70% of the Stevens-Johnson syndrome develop the ocular complication. At least in Japanese, for instance, allopurinol or anticonvulsant. These are not so closely related to the ocular complication. At least our experience. I'm not so sure here in Vietnam. And then plus antimicrobial agent and NSAID, especially the NSAID, is the one of the key for the onset of the Stevens-Johnson syndrome. And we performed some prospective study for the steroid pulse with the topical betamethasone, 5 cases or so, many years ago, about 10 years ago or so. And then all the 10 eyes maintain the palisade of Wood after the use of the steroid pulse with a topical betamethasone treatment. Palisade of Wood existence means probably at least in time that we can rescue some of the corneal arterial stem cells with the treatment. And all the patients did show the best-corrected visual acuity over the 2020. The reason is, I have already mentioned to you, this is the data of the tier, I think, cytokine, the level of the cytokine. So this is the cytokine level of the serum, and here IL-8, IL-6, and MCT1. These 3 cytokine and chemokines that is induced. Well. So this is a cytokine storm. The cytokine storm kills the corneal and conjunctival arterial stem cells. So somehow we have to avoid that. What about the scar, the stage of the Stevens-Johnson syndrome? This is we've been doing cultivated oral mucosal arterial transplantation. I don't want to say this is the best, but at least surgically we could do something for the Stevens-Johnson syndrome. Because Stevens-Johnson syndrome, this patient has a kind of innate immunity abnormality. So we try not to use not much of the steroid. So in this case, we have to stick to the autologous tissues. So to try to get a small piece of the oral mucosa on our mucous membrane, we create some of the cultivated oral mucosa bacteria. The cell sheet obtained from his or her own oral mucosa. Well, at the oral department, after the cleaning the oral cavity, take a small piece of buccal mucosa that you've already done here in Vietnam as well, and bring to the cell processing center. This is a amniotic membrane. There are many ways to make the oral mucosa arterial cell sheet. This is about 19 millimeter in diameter of the oral mucosa arterial cell sheet, 2 to 3 weeks after initial culture. This is a Stevens-Johnson syndrome. There are symblepharon and and also the scarring on the ocular surface. Try to remove it, and then this is the treatment by the microscopy, 5 minutes, 0.04%. This is the usual amniotic membrane transplantation. Try to inhibit the post-operative fibrosis of the conjunctiva. And then use the oral mucosal epithelial surgery, suture the liver region, and at the end of the surgery, we use the contact lens on it. She is exactly the same patient. Right eye is already blind. This is about 3 months after the surgery. Because we didn't touch the corneal stroma, they have some of the vessel growth or so. But at least she could make this kind of order. So it's not a 20/20 vision, but this is like a 20/200 vision. But still, she could walk or do something by herself. So this is just the few examples. We've done about over 100 cases or so. But so far, you can get some of the feeling of that. So this procedure is effective for some of the patients. Well, in addition to that, because we have some, the patient still shows some irregularity of the corneal astigmatism. So we developed the large size hard contact lens. And this is just approved by the Japanese Ministry of Health and Welfare. So now we can use this contact lens for at least the Japanese patient. So for instance, preoperative situation of the surface manifestation, and then 18 months after the surgery, calculated oral mucosal epithelial transplantation. And then when we use the contact lens, you could see reasonably well. So this is the subacute phase of the Stevenson syndrome. In both eyes, 3 months after dose. This is a very dangerous situation because it's so easy to get infected, and also sometimes it's so easy to perforate. So therefore, we decided to perform the COMET. For this side, just conjunctival reconstruction. For this side, we performed corneal reconstruction because this corneal stroma is healthier than this. And then, this is the kind of the ocular surface manifestation 3 months after the COMET or so. Still desiccated hand motion, and this looks okay. And when we use the large size lingual supported hard contact lens or so, surprisingly enough, the cornea becomes better and better because of the wettability improved. Even the right eye did show after the contact lens use. It's quite desiccated. This is a severe type of ACAS deficient, but when we use the contact lens, it's about 40 millimeter in diameter contact lens or so. And we don't, with the artificial tears or so, the surface become wet, and then he could see very well. So I think I will finish here. It's because of about 30 minutes or so. So this is kind of open of the dry treatment. Thank you very much for your time. If you have some of the question, I'm happy to answer your question.
Các bạn có câu hỏi gì với thầy không?
Yes, in case of the meibomian and cause the corneal complication, as you say, a cellular keratitis. cephalosporin that you use for this medicine?
I think whatever the cephalosporin, but usually I think either the macrolide, the minomycin, or these kind of the drug is also effective. So either the minomycin or the whatever you have, the cephalosporin. And then, but we cannot use that kind of cephalosporin for a long time. So therefore, initially, like 1 month or so, we use cephalosporin, and followed by the clarithromycin, low dose of the clarithromycin.
And how about
But if you could use the azithromycin is also very effective to the, I think, PI. So that is also the option.